Started. My name is Sue Swan-Blom. I am one of the quality improvement coordinators here at IPRO at the network program, and I am the home lead. So could I have the next slide, please? Just a few reminders as we get our call started today. Please, mute your phone if you're not speaking to avoid background noise. We'd like you to be present and engaged today in the program. We would ask you if you have questions or comments during the program to please utilize the chat feature. We would like you to pose them to everyone so everybody in the program today can see those questions. We will follow up with our presenters after each of their presentations and hopefully get those questions answered. And we just want you to know that all this meeting will be recorded and all the materials will be found on IPRO Learn or our network program website. Next slide, please. We have the next slide, please. Okay, just a little bit about our home modality quality improvement project. What our focus is, whoop, the slide just moved. Okay, there we go. What our focus is moving incident patients, and what they define as incident patients are patients who have never done another modality, patients who start dialysis on a home modality. That is the definition of incident patients for this quality improvement activity. That is a 10% increase over our performance of last year. Our prevalent patients, we would like to move more of our prevalent patients from incident dialysis to a home modality. That is a 4% increase we're looking at. And we want to utilize telehealth to engage our patients in home, and really just to utilize telehealth as a tool to keep our patients safe in their homes, but still have really comprehensive visits with them. During this project, we are tasked with using the NCC change packet. And then, of course, we are going to monitor the use of telehealth with all of our patients. That is something that is a self-reported data, and we will be asking that probably as a survey in our IPRO Learn platform. So we're going to ask you all to participate in that. And then lastly, we need to engage patients in our work. So we're asking each facility to nominate a patient facility representative. There are various levels of work. We don't want this to be taxing for patients, but some patients may want to participate on a greater level. So there's just a wide range of things that they can do to help with these projects, maybe from something as simple as reviewing a resource to participating on a national call. So the range is very wide, and we would just like to get as many patients, and that includes family members, also engaged in this work. Next slide, please. As you all probably know by now, we are utilizing an electronic learning platform called IPRO Learn, where we're posting all of our interventions for our network service area to go in and review and give us feedback. So just a couple of things that we have done over the course of the 4-month period. We initiated the use of the NCC change packet. Again, that is a requirement of our work. 80% of the people that looked at this said they would use this tool going forward. And really, there were no facilities that said they would not use this tool. Some of the primary drivers that they identified as important would be adopting a mindset of home first, educating and supporting staff and patients, and identifying a physician champion in your facilities. Another resource we just did last month was the MIE, My Life, My Dialysis Choice platform. It's also an electronic platform where you can lead your patients through priorities, and that gives them the option of which treatment modalities are best suited for what they want out of life. So we did have that resource reviewed by over 1,000 facilities. 875 said they would utilize that in their facilities going forward, but we were a little concerned because we had about 200 facilities that said they would not keep using this tool. And when we asked them their feedback, we realized that it was really a little bit difficult right now with staff shortages. This tool had to be used with a lot of the patients as a one-on-one interaction. It was very time consuming. It was kind of difficult for the patients to understand. And some of the facilities don't have an iPad or a tablet available to use. So we're going to take that feedback, and then for our next intervention, we may still utilize this in our toolkit, but I think we will do some searching to find something else that would provide the same information but not be so taxing to our facilities and our patients. Next slide, please. These are a couple of interventions that are going to be utilized going forward. We want to make sure everybody gets credit for all the home initiations they have in their facilities. And so we want to make sure everybody reviews each patient that has transitioned to home. The metric for this particular project is the home setting in EQRS. So not only does the modality setting have to be switched to home, but the QIA metric, the home setting has to be switched to home. So we're using this job aid and we are asking everybody to review their patients and make sure that is complete with all of our home transitions. We also are promoting a use of telehealth toolkit. It has not only a reference guide, checklists, and fact sheets for not only patients, but also providers, just to make that a much smoother transition. The checklist is really kind of nice for patients. It gives them an actual checklist of what they need to be prepared for their office visits or their telehealth office visit, what they need to have on hand, how to log in, what particular platforms they're utilizing, and how to discuss that with their facilities. For December, we're going to take a little bit of a lighter approach because we know everybody's kind of crazy busy in December, but we do want to still focus on our work. We are going to identify and celebrate with our top performing facilities. We will see who has transitioned the most patients to home in the last 4-month cycle, and we will identify those and post them to everybody in the network service area. We also would like individual facilities to post a picture of the patients that have transitioned to home. Put it in your facility so other patients can get encouraged and see that a patient has done that, one of their friends. So, and of course that comes with a permission to do that, but we would ask everybody in the facilities to kind of take a look at that resource. Next slide, please. Now I'm going to turn our program over to Terry Jacobs. She's the Regional Vice President for Fresenius Medical Care, the Western Ohio region. I have had many conversations with Terry, and I'm going to tell you she's doing some very innovative and exciting things in her region. She has so much enthusiasm and passion for transitioning patients to home modality, and her excitement is really contagious. So I'm going to turn it over to her and let you hear all the wonderful things she's doing in her region.
Thank you, Susan, and thank you for allowing me to have some time to speak to everybody today. I'm really excited. And so, hi, everybody. I'm Terry Jacobs. I am the Regional Vice President for Fresenius Medical Care, covering the Western Ohio region. The Western Ohio region includes Cincinnati, Dayton, Lima, Toledo, and Mansfield, and we also have 2 facilities in Kentucky. I am a regional vice president, but more than that, I am a home advocate. And to give you just a little bit of background, and I know there's a lot of you out there that I know and I've met over the years, but just a little background really quick. I've been in dialysis for about 10 years, and I've worked with both of the big companies, and in between that, I was able to work at Next Stage. Working at Next Stage changed my life. It really did. I've always been a hard worker, and I've always liked to do what I did, but when I went to Next Stage, and sometimes I still pinch myself that I had the opportunity to go to Next Stage. Working at Next Stage, you really got to work around a lot of the pioneers of dialysis and really learn from the people who have been doing this for years and years. And so that was a really, really exciting time for me to really have an understanding of home and how the machine works and what it can do for patients. Oops, I'm sorry. I'm having some problem here. So the biggest change was I got to meet patients. And of course, I always met patients in dialysis centers, but I got to meet a lot of patients who were wanting to go to home, but they were at all of our companies. They were Fresenius and DaVita and US Renal, and they were everywhere. And they would call us and they would say, can we do home with you? Because for whatever reason, they couldn't do home in their facilities. And so we would take these patients in, and the change that I got to see with the patients, they had more energy. They decreased their post-dialysis time. their recovery time. They were coming off their anti-hypertension medications. They were sleeping better. They were less depressed. They had higher scores on their physical and mental components. I mean, their life was just better. And I couldn't believe what I was seeing. And so right then I just had this new passion for my job. And I really felt like this is what I have to do. And being in these positions that I have been lucky enough to be able to have, I can make change. And I really made it my life goal at that moment when I was working at Next Stage to take as many patients home as possible and to really make sure that we give every patient the opportunity to go home because they deserve it. They're at their worst when they're sitting in our chairs in center. So they can only improve from that. So sometimes we look at those patients and we say, oh, they're just too sick. Well, sometimes they're too sick to not go home. Like they have to go home so they can have some life improvement. And so the way I always kind of refer to that is we have to let everybody know that dialysis 3 days a week was made to keep people alive. Dialysis 5 and 6 days a week will make someone thrive. And it's a big, huge difference. And so again, the way I like to put this sometimes is we've been putting people in the jalopy of the cars and they could drive the Cadillac for free. They just don't know. They don't know they have the opportunity to go home and be able to have that resource to feel better and to get their life back. So here's the agenda. And we're going to move through the agenda. We're going to talk about home dialysis post the executive order. And then where do we go from there? We're going to talk about some barriers to home penetration. And most of the time we're going to spend right in the area of strategies to increase home penetration. And then we'll just talk about a few other things that we still need to consider, things that are going to be coming in the future that we have to be ready for. So next slide, please. So on July 10th, 2019, the executive order comes out, right? And, you know, our company is just spending time pouring through this to try to tell us what it looks like and everything. And this picture, it always kind of makes me laugh because this is a river in Honduras. And in 1998, there was a hurricane. And after the hurricane, they came back to survey the land and you can see all the roads on both sides of the bridges are gone. The river has moved. And so the river was, you know, the bridge was no longer good to get access, to get across the water. And that's kind of where I felt like we were with dialysis. The strategies we had developed in all of the previous years before were like that bridge. They were not going to work for us anymore to be able to get patients home the way that we need to by the executive order. And so we had to really think about what new tools we want, what the path is going to look like, and how we are going to get across that water to get to the other side where we're supposed to be. So next slide, please. Okay, so after the home dialysis post executive order, this is what we were looking at. You know, 80% of new incident starts going to direction to home dialysis or transplant, 25% home penetration by 2022, clear paths for patients to transplant, and clear paths for patients to a home modality. And this looks all easy on a piece of paper, but you know, this isn't what we had been doing. And so we really had to rethink the way we were doing things and try to find some new tools. So next slide. And going on that too, remember when this all first happened, so many people were like, we can't do this, this can't happen. And what we really needed to do was say, you know, this can happen, but let's take a look at why we think it can't happen. So what are the barriers to home penetration? And you know, this is my list of barriers to home penetration, but I would imagine that all of you have a list like this, and a lot of the same things are on the list. So lack of physician support for home. I think we have some physicians who are very supportive of home, and we still have some physicians who are not supportive of home. So we need to get them on board. I think it's funny sometimes when the patients say, you know, oh yeah, I'm all about home for the right patient. You know, I mean, and we still have that part, and that leads into the cherry picking. So then we have cherry picking patients, and we've been doing this for years. So as long as I've known, we would pick and choose who we thought could go home by how they presented in the facility. And that's, you know, kind of what we refer to as cherry picking. the next thing was we had a lack of education for patients. So we were all the companies were starting all these amazing education programs, but we were having a hard time getting the doctors to refer to our educators so that we could get them educated before they were in our facilities. And so we had a lack of education for patients. And then also we have a lack of education for employees that are outside of the home modality. And I know this for sure because I was a manager of a facility years ago when I started, and I had a home program in my facility, and it was HHD and PD, and I didn't know anything about HHD or PD. I had the chronic mindset. So I was a chronic manager with home in my facility, and that's the truth. I really didn't know much about home. I just knew that the home nurses took care of it, and they were in the back. And even though I was the manager of the whole facility, I didn't know much about home, and now it's embarrassing to me to even say that. But I think we find that with a lot of our employees at home, in center, they don't know much about dialysis. They know what they've learned from the patients that come back in, the ones that had an infection or they failed, and so it's never sounded really great to the patients that work in the facilities. So another part is we have a lack of processes to retain our patients at home. You know, it seems like sometimes as quick as we're putting new patients on home, we're also losing patients back to in-center. And we really needed to be able to find a way to stop that. And then we, you know, the lack of processes from moving. And I think, again, that everybody's working on these things. The lack of process to move PD to HHD instead of back into in-center when they fail PD. And my problem with this area is we all know they're going to fail PD. It's not a forever modality, and that's why I love that our machine is called Next Stage, because it literally, when we meet those PD patients, we have to depend on our nurses to educate them and to tell them, you know, this is PD and this won't last forever. So the next stage, it's literally the name of the machine. The next stage is HHD dialysis. And I think if we can start those conversations early enough with confidence, that people will just understand that that's a natural transition. But we're just not very good at it yet. We're working on it. It's a work in process. And then also, I think this is the biggest barrier. Patients, employees, and physicians, many are still very skeptical about all the patients going home. I think they're still skeptical that it's possible, and they're skeptical of how it's going to happen, and they just don't believe it. So those are some big barriers that we're really faced with here. So next slide, please. So with those barriers, we come to, what do we do? Like, how do we actually start to move toward the model that's been set up for us? There's so many different paths that you can go down, but what should we do? What are the tools we need? What is the focus that we really need to have in order to move these patients from in-center to home, and from the hospital directly from home, and hopefully we're getting them in the nephrology practices and moving them straight from home from the office. So next slide, please. Okay, so now here are the strategies, and this is the strategies that we're trying to use in our facilities. And I'm sure that a lot of these are going to be very familiar to everyone. Initially, you know, transitional care units. So, and real quick, I first have to acknowledge my team, because I know I get to present this, but there's a whole team of people who make all these processes. I have amazing directors and amazing market managers, and I have to make sure that wonderful Next Stage team that helps us develop all this education. And we work with them very closely to put all of this on and make it go. So I just want to put those thank yous out there, because believe me, I'm the leader, but I am not the one who's work. There are tons of people out there working really hard to make this happen. But when you think of the transitional care units, I really believe this is the model for the future. So I think in the future, once we can get this all down, that patients will come out of the hospital, they'll go into transitional care units, they'll get all the education, the special attention they need to make a good decision about what the choice they want to make for modality. But unfortunately, right now, even though we're opening transitional care units, they're not something that you can just open in a day. They take timing, and sometimes there have to be projects, and we need to expand our facilities, and there's a lot that goes on. So yes, we definitely need to keep working on transitional care units, but we really couldn't just wait for that to come to fruition and be dependent on that to move our patients. So I think probably everybody in all the companies also have some kind of program around doing some HHD with an HHD machine in center for the in-center patient. You make them feel the difference or experience the difference or whatever it's called at your company. And I think this is an amazing opportunity too. So I think this is, it's worked. We have a few of these programs within our region and they're very successful. Um, the problem with this one sometimes is we have a lot of staffing issues right now. And I say that we, because we all do, right? And sometimes this kind of dies out or we don't have somebody to run the machine or something like that happens. So again, this is something that I think is amazing. Most of the patients do transition into the home department, but right now it's another one of those things. This couldn't be the only tool we had. Yes, we want to work on this. Yes, we want to have these programs working, but we need to move faster than what we can move with this. So we need some other things. So the next one was retaining current home patients with respite. You know, that's another strategy is we really have to figure out how to keep patients in home. And is that with the use of respite? Is that the use of doing biannual retrainings for confidence? Does it look like we need to come up with some caregiver support groups? You know, these are all things that we're thinking about and that we're working toward. Another thing that we've been doing is teaching patient self-cannulation in center. And it doesn't always have to be in preparation to go home. Sometimes it can just be giving a patient power, you know, giving them the power. And if they're ready to learn, and this isn't happening in all of our centers, but we do have a few of our centers that are doing this very successfully. But once a patient realizes they can cannulate themselves, the move to HHD is much easier because you know that that's what holds a lot of patients back from going to HHD is the cannulation piece. Now, those are things, the things that we've talked about so far are really things that we're working on, but we are not great at it yet. We're putting a lot of effort toward it. And again, I do think that transitional care unit is where the future is. I think that's how it will happen in the future. But until we can have those set up in all the facilities and all the regions, we have to have other means to move patients to home. So the next things I'm going to talk about are the things that we've really been doing in our facilities that have made a big difference. And it's been really a lot of fun doing it too. And so it started with Dayton. So in Greater Dayton, we started a program, I'm going to say about 2 years ago now. And it was, we wanted to move patients from in-center to home. And so we took one tech from each facility and I think the training was about 4 weeks and it was like 1 day a week or a half a day, just a few hours, 1 day a week. And we trained the PCTs about home. So we had a day where they were with an advocate and that they got to talk to the advocate about what it's like to be at home. We had a day where they saw how to set up machines. And then we had some days where they were just learning the medicine behind home and the improvement at home. And then we had a graduation and it was a big celebration and we did all kinds of fun things, but this really helped us. So in Dayton around that time, we started, and we did this it's still happening actually, about 12 months in a row, we moved 1% of our patients from in-center to home. And so we were really moving a lot of patients and we had this great process going. And it's been very successful. Still to this day, they are still moving patients home that way. And there's always contests around them or games or, whatever we can do to get the energy around it to make people think about it. It also makes the teams have a little bit more fun because we know how stressed out people are. And it's just a way to kind of win something for your facility. So we did put a lot of attention toward that and we made it very successful. So then we decided to take it out to the other areas. So then we took it to, we started doing the trainings in Cincinnati and Toledo and Mansfield and everywhere. And so we came up with ambassadors for all of the areas. We did this training a little bit different because we were able to get back in person. And so we had it at event places and we worked with Next Stage set up all the training and they did an amazing job because we changed it a little bit this time to where it was all hands-on. So they spent the morning just learning about the care of home and how it happens and why it's good for a patient, and they learned all that. But then in the afternoon after lunch, it was all hands-on. So they had 4 tables set up and the employees really got to set up an HHD machine and they got to do a PD machine. And they were excited. Like, and during this time, I was there, and one of my directors was walking toward me outside of coming out of the room, and I had this aha moment because he was walking toward me, and he had been part of the tabletops, and he said, I can't believe how easy that HHD machine is. And so I just right then I'm looking at him and I'm thinking, oh my gosh, you have been in dialysis for all these years, you know, a lot of years, and you've been around these machines all the time, but you never knew how easy it was. I mean, this is just what's going through my mind at that time. And I just say, we have to take this to everybody. Everybody has to see this. And so I get back with my team and we get back with our next stage team and we say, what can we do? Like, how can we make other people see this? So we came up with the idea to ask to go to the physician groups and ask the physician groups if we could train their nurse practitioners. And so again, our partners at Next Stage came up with a new kind of training. It was about a 4-hour training that still had hands-on. It was still going to be that hands-on. We're going to show you how to put this machine together and show you how easy it is for a patient. So the doctors agreed. And so we started setting up our nurse practitioner training, and we were training the nurse practitioners that round in the facilities, that work in their offices, and then also round at the hospitals. And it was great. So initially we only did HHD training, and then they wanted more training. So they're saying, you know, can we do PD? Can we do PD too? And so then we started setting up PD. And so I'm super excited at this point because more and more people are just getting to see the machine. And they're seeing how easy this is. You know, for some reason, there's this block in people's brains that tells them home HHD must be really hard because look what it's like in center. Look at that big machine and look at all those buzzer, you know, look at all the stuff that's going on with it. Look at how the blood pressures are all over the place. And so people have just put it in their brain that this is hard, and including us, including the people who do dialysis. So, you know, being able to help those nurse practitioners get through that too and have an understanding of, hey, our patients can do this. This isn't that difficult. So now I'm really excited to say that, again, working with Next Stage as our partners, we're doing physician training. So we have our first physician training scheduled for December 1st, and the doctors have invited us to their monthly physicians meeting. And we're going to do hands-on with the physicians and the Next Stage machine. So we're really excited about this. But I think, and you know, then the next one, there is a path for in-center to home therapy. So again, I'm still always ready to push patients home because they deserve to go home. And so we're like, what else can we do? You know, what else can we do to keep this energy going? And so we decided that we were going to continue the ambassador training, and that's what we called our PCTs that we trained. They were home ambassadors. And so we're going to continue that, and we're going to do bi-monthly training, but we're not just going to train ambassadors. We're going to start training everybody. So we want the managers there. We want the dietitians, the social workers, the admins. We want everybody to learn about dialysis and learn about these machines. And kind of when I thought of it this way, and I thought, oh my gosh, if we could have our whole team understand what I understand about home, then everybody is going to want to send all the patients home. And, you know, it's not as great as it sounds right now, but we're working hard on it. And it has really been working for us. So over the last year over year, we were able to increase our penetration more than 3%. And in the month of September for the Western Ohio region, we finally did hit the 20% penetration as a region. Now, a couple of my areas, consider Dayton and Cincinnati, they both are in the 25% and above penetration areas. So I think this has been working for us. We're gonna keep on trying to find different ways to engage people, but I think that we are, I think this has really been working for us. And so the one thing I want to say is if we want all patients to go home. We want your patients to go home. We want our patients to go home. And when I talk about home so much, I also want to make sure that people understand it's really not about the place where they're going to dialyze. It's about the more frequent dialysis. So we always say you have to go home, you have to go home. But what they really need is they need more frequent dialysis. They need to dialyze 5, 6, 7 days a week so they can feel as normal as they can possibly feel. And I think that we're helping get them there. So very exciting stuff going on. Now, there's one more thing I want to share with you that maybe can be helpful to you too. It was pretty helpful for me with some of our doctor groups. There's this thing that happens with physicians sometimes, and this is a negative about physicians. I love physicians. We wouldn't be able to do what we do without physicians. But sometimes, and I'm sure a lot of you have seen this too, our physicians, for some reason, think that they're more accountable for the patients at home than they are for the patients in center. And a lot of times that's why they'll tell me that like everybody can't go home because they're non-compliant, but there's really not a lot of difference if they're non-compliant in center or if they're non-compliant at home. And I think that one thing we have to make these doctors understand and make the physicians understand is we don't just pick them out of the chair and send them home. There's all this training and they have to pass the test and they have to get their skills checklist. And if they can't do those things, then of course they don't get to go home. But hopefully they will get to go home. But there's a V tag. And there's a bunch of V tags about home, but this is the one that I picked out. If you want to go to the next screen, it's V458. And I worked with our regulatory person to come up with this. And this is the one that I've actually been printing and taking to physician meetings with me. And the reason that I like this V tag is because it says, it says right in that top, the line of the second part, documentation and patients' records must demonstrate that facility staff provide unbiased education to patients. And so that's our job. We cannot be biased when we do this. Every patient should have the opportunity to go home. And is every patient going to go home? No. Some patients are, no matter how much we tell them about it, they're still going to want to come in center. And some patients just physically are not going to be able to go home. They're not going to be able to do what it takes to go home. And then, of course, some patients don't have a home. So, of course, they can't go home too. But I think the biggest thing that we all need to understand is we shouldn't be picking and choosing who gets to go home. That's really deciding who gets a better life and who doesn't. And I just think that if we can look at it that way and start to see those dialysis patients with that they all get the same opportunity. Every patient should have the opportunity to understand about dialysis. So that's not just a walk by their chair and say, hey, are you interested in home dialysis? And they say no, and we go, okay. But really make them understand about home dialysis and how it can improve their life. And that's just something I'm really, really passionate about. And so this is a tool. It's helped a little bit. It's helped with the conversation with the doctors to understand that nobody's expecting the doctors to be accountable for those patients at home any more than we're asking them to be accountable for the patients in center. And so this was just a VTAG that I thought might be a little helpful to some of you too that might be having those physician conversations that are difficult. So next slide. So just some other things to consider. When we really talk about sending 25% of our patients or 50% of our patients home, what does that look like? So and these are all estimated numbers that I just kind of came up with. But so if you have an area, I know that every company calls them different. So if you have a region or an area, but like Dayton, and say maybe, and this is a guess, but say maybe there's 500 patients there in this area. So we have to get 125 home for 25%. What does 125 patients look like in your home programs? How will it be managed? How will the staffing model look? How will you take these rooms and be able to take care of 125 patients in them? And then just to think that a few years later, we're going to need to be at 250 patients or somewhere around that at home. What does that look like? What do the new home? And so I think this is something we need to, maybe it's not in front of us right now, but we need to have some thought about how this will look so we can become prepared for it. And in that same staffing model, we need to think about, and I know that we're starting to hire PCTs and LPNs into the home programs, but we really need to think about how we can most use them very efficiently. How can we use them? And I know we're all understanding now what they can do legally, but where do they fit in the flow, the process flow? Like how can they be effective like they are in a chronic unit? And so I think it's going to take all of us. It's going to take the whole community of dialysis to really work these things out. And then strategies, like what are the new strategies going to look like? And a model that I don't know if it's coming for sure, but it just seems like it would make sure is to have trainers and caseworkers. So now when you go into home, maybe you're not a home nurse, you're a trainer or you're a caseworker, or maybe you're a greeter, but to actually have identified different jobs in the home department. And then the in-center staffing issues and the focus to reduce in-center patients, right now is very critical for most of us who have staffing issues. And so that's what I say on every call every single week. If we move patients home, that's less patients that we're going to have to take care of in center. If you can move 4 or 5 patients home, you just took a pod of patients away for your in-center to not have to worry about. So I think that, these are things that even though they're not right in front of us right now, we really have to start thinking about what they're going to look like so we're ready for them when they come. Next slide. So questions.
Thank you so much, Terry. Again, your enthusiasm is just overflowing, and we thank you so much. But I do have a couple of questions.
Sure.
I had a couple of questions posed in the chat, but one is about a facility that has an older population. This one particular facility has an average age of 71, and they want to know how they can encourage and engage those patients to transition to home.
I think this is always a question that comes up. And so I really think it's about having that engagement with the patient and family if needed. And this was an example I used recently. My own mother is having some kidney issues. And so she's at stage 4. And I just thought about, as she goes to her appointments and she discusses it with me. And I just thought one day, like, what if my mom was on dialysis and she was in center? First of all, my mom's 80 years old. So they're not going to look at her like she is a home patient. And so I really thought about it, like, what if I didn't know anything about home? What if my mom was having these kidney issues and I knew nothing about home, and they were going to put her on dialysis and put her in center, and they were just going to look at her by her age and by, how she looks and say, yeah, she probably can't go home. And I thought how angry I would be, because the one thing about those patients that are in their 70s, they have lots of family, and lots of family that if the family understood how much healthier the patient would be if they were dialyzing at home, that they might want to help. They might have somebody that wants to help them at home. And, any kind of caregivers that will support those people. Now, we have all seen patients in their 70s and even in their 80s who can still do home dialysis on their own. They've learned the cannulation, they still can do the technique on their own. So can we move every patient that's, in 70 plus home? No, but we need to talk to them about it, and we need to educate them about it, and we need to make sure there's not a path. I think that's the way you look at it, is you got to make sure there's not a path, because there might be a patient that we don't know about. Maybe they have a granddaughter that's a nurse. Maybe we just don't know until we have the conversation. So I think it's really important in those times to make sure of the education and bringing the family in, asking the family to be part of the meeting. I hope that's a good enough answer, Susan.
Yeah, I think so. But we also have another question. There's some people that are commenting about rural facilities, and that there's really a barrier getting patients to training. They have to come every day for a couple of weeks at least and get signed off on everything. Is there any assistance for transportation, or are there any alternate ways that you train patients to help with some of that transportation problem?
It's a problem in the rural communities. It is hard to maybe, when the next dialysis facility is maybe 40, 45 minutes away for a patient. The thing is, we just have to try. We can't say no. Maybe there is a patient that can't find a way, but maybe there's county transportation or senior citizens transportation or veterans transportation. Or, it's just kind of being prepared to do the homework and saying this patient is worth the time that it's going to take me to find the resources.
And then we have another question. Again, this is more with the transportation issues in rural patients. They're wondering about legality of utilizing a technician to maybe get treatments initiated or to do some training actually in the home. Is that anything that anybody is utilizing now?
So I don't know that people are actually utilizing it, but there's a lot of conversation about it, and maybe not with we can't send a PCT in to do initial training, but we have done some training at home for those patients that can't. So we would send the nurse in to do the initial training, but we could always also send that LPN PCT back after the training to do, to help with those first initial treatments that they're doing. So I think it's just something that we're all going to have to think about and think about how we can make it happen. But I do see a path toward treating patients at home and training patients at home. definitely. I think we're going to have to find that path also.
Yeah, that's great. Well, I know you're under a little bit of a time constraint, so I don't want to hold you. We don't have any more questions, but just
Okay.
congratulations to you and your team. 25% home rates and 20% home rates in your region are just phenomenal. And, we just really applaud you all for what you're doing. I have to tell you, I've had some conversations with some of your staffing, one of your technicians, and actually one of your patients that's done and experienced the difference. And they are incredible ambassadors for your program. So I don't know what
Good.
you're doing there, but thank you to you and your team.
Hey,
Thank you so
Sue.
much.
Sue, I'm sorry. And hi, Terry. How are you? This is Vicky. Do you have
Hi,
just one
Vicki.
more minute for a couple? We're getting questions privately
Sure.
through the chat, so no one else is seeing. So Laura, our hostess, is like sending them over. So one person asked, if you have patients that live at home with no support person, what do you do to handle that?
Well, it has been approved to do HHD solo, but these are discussions that you have to have with your physicians. And so there are wonderful ways to set patients up to do HHD at home solo and keep it very safe. But I'm not going to tell you to go out and do that without speaking to your physicians, because of course that's something that's going to have to be governed body into your facilities and something they're going to have to be agreeable with. But if you are working with the next stage, there's truly a lot of things. It's like, if you're going to be at home and dialyzing by yourself, you tell the fire department, you go to the fire department before, tell them, I'm going to be dialyzing. These are the times. This is how I would like you to enter my home if you need to. If I call, I'm a dialysis patient. They also have it now where, we have so many devices that we can talk to that can unlock doors, or, letting our neighbors know we're on dialysis. There's just so many different ways to approach that, but there is a lot of solo HHD going on. So, when I was at Next Stage, we did a lot of solo Next Stage, a lot of solo HHD, but we also did nocturnal solo HHD. Always successful. Even in our programs now, I think now it's just going to be getting the doctors on board. I realize that there's a lot of patients that would be willing to go home if they solo. So it's going to be us working with the physicians, making sure all the education, making sure the physicians understand that we can make it safe. We can make it safe for patients to dialyze by themselves.
Well, and I think you've got some unique ideas with the technology nowadays, and ways to
Right.
make patients feel better about it. We also, how do you get anemia management to homebound patients was a question that came in.
Well, I think you're going to do it the same way you do it chronically, but you're going to have nurses who are working with those patients. So if we have to bring patients in to help with anemia, and maybe our HHD patients are doing their own labs and stuff at home, but maybe we're going to have to bring them in if we have to, if they're not taking care of it the way they're supposed to be taking care of it. So I think the approach is the same center. It's just the communication maybe is a little bit more difficult, and we don't always know that they're giving it, but I think that's going to kind of be on the nurse and the team to follow it and realize what the needs of the patient are. So even if it's that we have to take the nurse to the home to give medication, that's, again, it's just about finding things that we haven't done before and figuring out how we can make it happen.
And just two more questions. One is, and I saw this with the elderly person too, the idea that the dialysis center is their social life, and going home they lose that social interaction. Have you had any creative or successful strategies to get them re-engaged with their community so dialysis isn't their only social action?
Well, and of course, this is a question that comes up all the time. And the thing that we really like to interact with them is there's nothing says they can't come back and visit the patients. That's the one thing, is you can come back and talk to your friends about home dialysis. So there's nothing that says you can't. But we also ask them, what did you do before dialysis? Like, those are things that you're going to feel like doing again. You're going to have the energy again to do the things that you used to do. And, these experience the difference, whatever they're called at your company, where we are using the HHD machines on the floor. I think that's where we really get that bump. And people are like, oh my gosh, I usually go home and take a nap, but I went home and painted my fence yesterday. And it only takes a few treatments to get them feeling better. It's not like it takes months or even weeks. If you can get them to come 2 weeks in a row, by usually that third, fourth, fifth visit, they're feeling totally different. So I think it's just making sure, again, it's just knocking down the barriers.
Correct. Correct. I get you. And I mean, one of the questions was about, is this with pediatric patients? But I know the answer is no, that you primarily work adults, right?
Right. We don't have any pediatric patients, but I think with parents becoming advocates for their children, that if they're educated correctly, that most patients would want to take their kids home, or most parents would want to take their kids home.
And I think that is a focus. So, well, thanks. It was great seeing you again, Terry.
You
were
too.
great.
Nice to see you. Thank you again for
And
letting
thank you
me
for the great
talk.
presentation. We really appreciate it, and we might send you over a couple questions after. I know things have been coming through privately, and I don't want to keep you on too much longer, but if we get some more, maybe we'll hit you for a couple more questions.
Sure, no problem. I'd love to help anytime. Everybody have a great day. Thank you so much.
Thanks, Terry.
Bye.
Bye. Well, it was really a wonderful presentation about home, and we have another speaker lined up to share with you about transplant best practices. So I'm going to just do a little lead in to kind of share with you where the network's at. So if you could change the slide. In terms of what our goals are for transplant, we're looking at in the 5 years getting a 20% increase in patients added to the wait list and a 30% increase in patients receiving a transplant. So there's a amount that we're looking to increase every year to meet that goal. And this is heading obviously for the American Advancing Kidney Health Initiative. And in order to do that, CMS is requiring that we all look at the change packet and try to use some of those interventions and drivers to help us work through those. Those are time tested and approved interventions that were worked through in transplant. We also have, very excitingly, we're working now with the TACL or the ETCLC contractor, and their whole role, this is a new contract within CMS, and their whole role is to make more organs available for transplant, lowering discard, improving use of maybe a less than desirable kidneys, as well as even maybe getting into the living donation sector. So while we're trying to raise this amount of patients who are interested in pursuing transplant, CMS is also trying to align a great deal of national work to get more kidneys out there for transplant. And then lastly, one of the other requirements CMS always asks us in all our work is to engage patients. So we can move to the next slide. So, we've been working with all of you. We know that most of you have very, very good resources and practices that you have in place through your organizations to assist with transplant. But we always like to add and share those things that are required from CMS to be working with, or additional resources we have that we think would help support your education and communication about transplant. So for the last couple months, the first offering we did was review with you all the NCC change packet that is posted on our IPRO Learn and the toolkit. Really 85% of the facilities that looked at this said that they would use this change packet and the tools in it. They really, from a selection point of view, they talked about creating a pro-transplant culture, continually following up on the transplant process and staff education as some of the primary drivers. That's what you told us are the things you really see that you need to work on to make these changes in transplant happen. The next month, we shared with you some work, this transplant word search. It's just a fun way to engage patients in what they like to do. And when you combine these two together, we had about 89% of you that said you would use the tool one way or another. And I put some of the comments there, that patients do love word searches and other puzzles, and it keeps them something to do while they're on the machine, as well as it helps to remind them about transplant and give them some education. So that was one of the comments I pulled out of your feedback. So we really appreciate you sharing your input and looking at these resources and figuring out how they may supplement or aid you in an area you might need or have a lack of resources. Next slide, please. Coming up, right now, what's loaded in the system are a lot of tools that help you do these referrals for transplant. So a tool that is a checklist reminder. I know I've sent this out to a couple of you already to say, because you say patients lose track of where they are and what they need to do. So this is every possible appointment the person could have in the transplant workup is listed there, and it could be used as a tracking tool for the patient. Another really unique and I think important tool is the waitlist set of tools that we have. One is called Help Your Patients Waitlist. That's for you to read and understand the different ways you can help them wait less on the transplant list. But there's also this complementary piece that's for patients, and it really talks about, would you consider a kidney with a high KDPI? Would you consider a kidney that, maybe was from a person that was less than desirable? Maybe it has some, problems on transport, but the surgeon feels good about using it. That's going to open up a lot of transplants for people. And there's more and more data coming out about how the 3 or 4 years that kidney would last will add to that person's life much more than skipping it for the optimal kidney. So, even if it doesn't have the longest survival time, it is still better for them to get a transplant than to wait 10 years on a list. So these are some of the things that we need to kind of open our minds to, and we're sharing these resources with you to help do that education, because there may be people who that next year they may not make it still on in-center hemo, and that's what people are finding. And lastly, we want to celebrate success. We have some posters and pieces there. We'd love you to put some pictures up if you have the consent of your patients, or list people who have gone on for transplant, and even waitlisting. That's an important big step. So you can make this a newly transplanted, newly waitlisted celebration. Those are both great things to keep the communication going. And in the middle of the slide, a little complicated and hard to see, but this is an excellent referral guide. So if you've hit the road where everybody seems to be medically ineligible and you don't have other people to, refer for transplant, it's a good time to go back and say, when were they made medically ineligible? What was it? Can we help that now? Is their infection cured? And really go back through your list. And it gives you a lot of ways to, just do that thought process, think through those individual patients, and maybe get another group to refer. So with that, knowing our interventions and what we're sharing with you, I'd like to present our next speaker. Next slide. And I'm really happy to have Holly Rodriguez, a social worker from US Renal Care Dalton, Georgia, to speak to us today about some of the great work they do at their facility promoting transplant. And we're really pleased that she's able to take the time to share that with us today. And Holly, do we have you on, or can we hear you?
Hi, yes, I'm here.
Perfect. All right. So I'm going to turn it over to you, Holly, and I really appreciate you taking the time. And you just tell us when you want us to move the slides. We'll go to the next slide now.
And Holly,
Okay,
you have the ball.
Oh, she has the ball. Oh, she's doing it herself.
Mhm.
Okay.
Awesome, thank you. Hello, my name is Holly Rodriguez. I'm the social worker at US Renal Care Dalton and Dalton Home. I have been with US Renal Care for a little over 2 years. With that being said, I'm hopeful that even though I'm talking about what has worked at my clinic, I hope that this just helps you to open up the conversation for what could work at your clinics. So a little bit about my clinic. I consider us to have a high patient population. We currently have about 105 patients in center and about 35 patients that do peritoneal dialysis. Of those patients, 31 are active on the transplant list, 9 are in the evaluation process, and 10 are still in the referral phase. Our clinic and nephrology office primarily uses these 3 transplant centers, Vanderbilt, Emory, and Piedmont. Thankfully, these transplant centers are very active in keeping us informed of our patient statuses. However, as I'm sure we can all relate, it takes more than just reviewing the transplant updates for a clinic to thrive with the high patient transplant numbers. And while I was thinking about what to put into this presentation, it really all comes down to communication. And what I mean by communication is communication between the referral point of contact and the transplant center and the patient, communication between the transplant center and the dialysis facility. The lines get crossed, and it can always get confusing on who is doing what. And with having so many different people involved in the process, as I just mentioned, the lines can get blurry, overwhelming, and exhausting for one patient to deal with all on their own. As you can see with my expert line work, that there are quite a few different people involved with each person's transplant status. And most clinics have more than one patient on their list, so having to keep up with everything can be very tiring. Which takes us to our next slide of common questions that we ask our patients. Have you called your transplant center within the last quarter? Do you have their number? If it says that you need a colonoscopy, when was the last time you had one done? Do you have a family support plan? And 9 times out of 10, when you ask the patient these questions, we get the famous blank stare and quiet pause before the inevitable, I don't know. They tell us, I don't know, all the time. And we at the dialysis facilities will find ourselves struggling to find the answers to these questions. While we do have some records, of course, sometimes we are not wholly informed, and finding the answers is a task in and of itself. And just like our patients, no transplant center is the same. Each one has different needs and requirements for their referral process. And this is going to take us into what works best for our clinic or what we've been working with. So for my clinic, we do weekly IDT meetings. So I'm sure everyone here can put together what this consists of, but just in case, this is what it looks like at our clinic. So for our clinic, we have scheduled weekly IDT meetings on Mondays that consist of the following team members: our facility administrator, a nurse practitioner, our clinical coordinator, the social worker, myself, and our dietitian. Now, I must preface this by saying that by having all team members present for this meeting is not something that happens every single time, but that's okay. Our goal is to have these team members together, but when we don't, we still communicate through email to ensure that everyone receives the information needed. These meetings allow us to talk about important updates at the clinic, upcoming admissions, discharges, and of course, transplant statuses. By working together with our team, we can work collaboratively to help each other with patient statuses and, for the purpose of this presentation, transplant status. And when we are discussing transplant, we are able to work together to find the answers to some of those questions that I had listed earlier. At these meetings, when we are discussing transplant, we basically go around the room, update each other on important tasks that need to be completed to assist our patients with their transplant referrals, evaluations, and what they need to do to stay on the transplant list. So for transplant, we discuss the status, if they're eligible to be referred, and our nurse practitioner really helps us to determine from a health perspective if they would potentially qualify to be on the list. The nurse practitioner also looks at where to send the referral. As I said before, each transplant center has different requirements, but our nurse practitioner is really knowledgeable about the different BMI guidelines, health screenings, and other requirements that each transplant center has, based off her experience with working with those transplant centers for so long. Our nurse practitioner is also a bridge to our nephrology office. Our nephrology office assists patients with getting those tests and screenings scheduled that are required for transplant. Our facility administrator and clinical coordinator work together in determining if the patient is compliant on dialysis and if they think they would be a good candidate for transplant. If a patient is frequently missing their dialysis or other scheduled appointments, or if they're not meeting goals established for their health, then these are things we try to address and rectify prior to transplant referral. Myself being the social worker, I determine patient needs, such as questions about insurance, compliance as well, transportation, and overall mental stability for transplant. I also encourage patients to think about transplant, having discussions with friends and families, and the implications of transplant. We also need to look at a patient's mental health, as a transplant process takes fortitude, patience, and hope. If a patient does not have the endurance to complete the process, or the patience of communicating with the transplant center, or if they do not possess the hope that they will get a transplant, then the likelihood of them completing the process is slim to none. Our dietitian works with us as well if the patient is compliant with their medications, which is something that's very crucial for post-transplant. I think we are all aware of the health complications a patient may encounter after transplant if they do not follow through with the medications. So those are the basic roles of the people who come to our IDT meetings. We each serve a different role, and we bring different perspectives to the table to assist our patients through successful transplant referral, the entire evaluation process, and post-transplant. Something that I think is also important to say is how different each patient's relationship is with each member of the IDT team. While one member may have great results with the patient, another IDT member may be struggling to have that connection with the patient. This is why it's important to get everyone's input in the transplant process. One member may say no, and another one may say 100% yes, this person would be great for transplant. And it just varies patient to patient. So try to be open-minded when discussing transplant. Remember that your role in this patient's dialysis care may be very different than what another team member has. Which brings us to our next slide, QIA. So we also discuss transplant statuses during QIA. This is when we are able to discuss any burdens, questions, and concerns with our medical director. Our medical directors are very involved with all of our patients, and I cannot give them enough praise for the amount of care and attention they give our patients. They are truly amazing. Since QIA is held monthly, this is another time for the IDT team to come together to discuss patient statuses, but with the medical director involved. The medical director also has a relationship with the patient and can offer their insight, thoughts, and solutions to what the IDT team may be struggling with. This also gives us time to talk about new referrals or to discuss patients that we may feel may not be a candidate anymore. So to summarize, communication is key to improve the number of patients referred for transplant at my clinic. Most patients new to dialysis are overwhelmed, trying to unlearn past behaviors with eating habits, limiting their fluid consumption, taking new medications with their side effects, having to rely on a machine to stay alive. These are all things we have to be mindful of. These aren't just people going about their everyday lives like the rest of us are. They have so many more obstacles to overcome. And these are things that are not often talked about regularly in our society, and people are completely unaware of what it all entails when they come to us, not to mention having to explain the process to family members and friends. Dialysis is so hard on the body physically and mentally. Then, on top of all of that, the tests, the procedures, the blood draws, and possible surgeries required to even be considered for transplant make this process even more overwhelming. Our team has not been having our weekly IDT meetings for very long, and sometimes we are all so busy that it ends up being completely by email, which is okay. At the end of the day, it's about what works best for your clinic to communicate important information. Your clinic, the culture of the clinic, the staff, and patient interactions all play an important role in referring patients to transplant centers. I hope this presentation gave you some ideas as to what your clinic can do to improve the number of patients referred, or at the very least, opens your clinic up for conversations about what could work for your clinic. Thank you for your time, that's all.
Well, thank you, Holly. That was great. I haven't seen, although we do get some privately, so let me just wait a minute. I guess my question for you, I think one of the unique things I find about your process is how invested your nurse practitioners are. They sound like they're kind of leading the way in terms of communication between the transplant centers and the patients, and they really get very actively involved. That seems a little unusual for a dialysis facility. Is that the right description?
Absolutely. Our nurse practitioners and our medical directors are heavily involved in pretty much every aspect of our patient care. This job that I have now is my first job in dialysis, so I don't really have any other experiences with other ones. But yeah, our nurse practitioners at all of our clinics, they always come, I think, at least once a week and talk to our patients, see where they're at. They assist them, like I said, with health screenings and stuff like that. So they are very involved with their care for sure.
That's great. We do have a question from an attendee. Do you, in your particular area, need a MD referral to transplant? Like, do your transplant centers hold you to that?
No, where we're at, we don't need an MD order to do a referral for transplant, no. But we do talk about it with the MD before we send the referral.
Right, of course. Yeah, I would say that that's a fairly, if a transplant center requires that, I'm seeing that kind of becoming an out of date. Transplant centers can even take patient self-referrals from what I'm seeing. So that's a little bit of an out of date requirement. Somebody's commenting about how envious they are that your nurse practitioners are so involved in the care and doing that, because a lot of them just do their rounds and check out. So I agree. I think that's a really unique phenomenon. So one of the questions, how do you feel about patient that has to take the COVID vaccine now in order to get a transplant process? It has one of their patients refusing and canceling their transplant process. Have you had any problems with that because they're requiring COVID vaccination?
Personally, at my clinic, thankfully, we have not had any patients say that they don't want to take the COVID vaccine to stay on the transplant list. I think most of our patients are thinking of the big picture, and that if they have to take a simple, COVID shot, to get on the transplant list and to stay on there, then they've already been through so much as is to get on the list that they're going to do it. I'm sorry that's happening at your clinic, though, that someone's refusing. But yeah, that's just a requirement now, like a lot of other screenings are. So we're just kind of like implementing that with everything else that goes on with the transplant process.
Yeah, and I don't know, whether you've seen the data, but the data, if you're already have a transplant and you're immunosuppressed, your ability to fight COVID is very, even if you get the vaccine after you're immunosuppressed, you get very low antibodies. And transplant patients have had horrible outcomes who have gotten COVID. So I think it's a really good safety measure for folks to get vaccinated before they actually get transplanted, because then they can fight that illness and live healthily with their transplant. So really important. And somebody is saying that it sounds like you have a great team, and they're struggling with staffing shortages, which is really undermining them. And I know a lot of people are in that boat right now. So any secrets you have about keeping such a good and included team, Holly, that you want to share with us?
Goodness, I wish I had any leadway in making this team so great. Fortunately for me, I just kind of came into it and I was able to get involved with this team. They've been great since day one that I've been here. Like I said, they're all super involved. We all communicate with each other, like I said, with the IDT meetings or even just QAPI catching up. We all just take the time, and we know how important it is, to be a team and to have that culture of care at our clinic. So I think it really just comes down to that, if the medical directors, if they have a great attitude, I think it kind of trickles down to everyone else, including the nurse practitioners, the social workers, the dietitians, and we kind of just have to, keep going with that, so that way the patients get the best quality of care.
Yeah, I think you really hit a big point there. It sounds like your medical director, your physician team is very, very passionate, and their leadership and then going through nurse practitioner, it pulls everybody together, right? So it's all cohesive. I guess one last question. What do you do for engagement and education with your new dialysis patients? What approach do you take on this with transplant?
For transplant, for sure. So whenever they first get started in our admissions process, I'll vaguely bring up transplant, just kind of plant that seed in their head and kind of see what their reaction is to that. Definitely before the 90-day mark, we'll follow up a little bit more heavily, see what's going on, see what their thoughts are. If we're able to pull in a family member or someone to be able to talk to them about that, that's great. But usually our doctors also round at our clinics once a month. So I'll kind of while we're going around from patient to patient, I'll kind of give them little tidbits like this one's not really wanting transplant, this one's thinking about it, or PD and stuff like that. So I think just keeping everyone educated and, like I said, kind of telling the doctors where they're at, so that way they can kind of give them more information, and stuff like that's really helpful.
Right. Well, thank you so much. I know we ran a little over, but people have hung on and listened, and I think they're all very interested and intrigued with your great staffing model and how you guys just kind of work it all together as a team. I'm gonna just, I don't think we have time to go through the wrap-up slides. I just encourage you all to get into IPRO Learn. And I hope you appreciated these best practice speakers that have come forward. They're working in the clinics just like you are, and but they're able to really offer some great suggestions and idea and energy to promote these modalities. And it's where we all want to be in the future. So I hope you've gotten a lot of great suggestions or something you can walk away and do. And we'd ask you to stay on and please complete the evaluation that's going to pop up after the webinar. And thank you for your time.